And when you say rest activity cycles, I guess that as they are patients and older, they get tired from physical activity and then they need to rest and probably they sleep also better. What kind of observations you have from this activity rest cycle?
Well, there's a psychopathometric instrument called the neuropsychiatric inventory where you see restlessness as a subjective rating. You can do the frequency, the severity, and the caregiver burden. This is the subjective part. But we also see objective ratings of restlessness. It's mostly based on sleep science, where we do have actigraphic recordings on the wrist. And then you see it comes from the night for the dream or the sleep quality analysis, where we see rest activity cycles like from the REM periods. It's also analyzed during the days. Normally times we have activity, rest. This is could be a cycle, but we see patients that are restlessness all the day, that need to be fixed, sit down for eating, going these 40,000 steps, as I told before. But we need measures for this because the staff is changing 3 times during the day. We see also patients wandering during the night, but in the recordings, in the nursing clinical recordings, we see the patient has slept in all 6 times the nursing staff was looking for the patient. So this doesn't come together if we see these recordings and the motion sensors and the nightly recordings from the clinical observations. You could say this is a relatively new field where we're also trying to get now with hybrid motion sensors, because these wrist activity monitors, they can only quantify an on-off activity, like 0 or 1. We also only see this is activity, this is not activity. And having these cycle analysis, you can't do anything with these cycles in a way that we could do exercise, for example, because they're not correlated to their steps. We know in an Italian study, they have just checked for the high activity periods, and they were correlated to their breakfast, to their lunch, and to the evening meals. And but the steps, they were independent from this. And also, we see some sticking activities having caloric value like a marathon runner, but they are doing handwork together. So this is not specific enough for clinical decisions, especially if we see exercise as a synchronizer, you could say as a Zeitgeber to stabilize circadian rhythms. We need such measures, and that's what we're working now on. For example, steps, having an active period, having the longest periods, sitting times, breaking up these sedentary behaviors. How can we do this? But we need this rhythm analysis also for the steps, for example.
So quite a bit of need for measurement, as the stuff is changing 3 times a day. So nobody basically sees even a 24-hour cycle, how they behave. Then you said that the restlessness is there. Is restlessness in a way that they just want to move, or is there some kind of tapping of the legs when they sit, or how is the definition of restlessness, and do you think it could be measured?
There are 2 different ways. You have the restlessness in the restless leg syndrome during the night. This is something that is also measured with pedometers, but we within the neuropsychiatric symptoms cluster, we have these behavioral and psychological symptoms, and there we see restlessness like a wandering phenomenon. Patients are searching something, someone, somewhat. We see this as a wandering towards something, and this is the most of the cases is that that we have this. But did you get? We're speaking about restlessness. We're speaking about this, but this is only a small part of the patients. The most patients, they are these hypermotor patients, but we don't get them. We don't get them in our hospital routines, and we need to be aware of both extremes, the non-active way and the hyperactive way, and then I think we're in a good way.
Mm. So you mentioned that there's some you're doing wrist measurement at the moment, and you maybe get some knitting as an activity, and then the needs are a little bit different for the patients in many ways than normal people, healthy people. So what would be an ideal tracking device in your opinion? What kind of things it should measure if it was designed for hospital use, and specifically, like for example, these patients that you are working with?
If we look into exercise referral or exercise prescription, it's the way of asking the patients on how many days are you active, how active are you, and so on. And this is something an actigraph can't do. We need, from our point of view, we need the body postures: sitting, lying, standing, gait. This is something transferable for the patient. We could speak with the patient on his level of physical activity and won't speak about counts. We could see steps, the level of steps, how many steps are you doing, the sitting times, the lying times. This is something applicable that we need. And in the second way, we seek for analysis of these parametrics, of these variables, for having when do we have the peak of steps? Is this related to a chronotype for the morning lark or the night owl? Can we shift our hospital routines or nursing routines together with these chronotypes we see in the physical activity? Because we see aggressive behaviors if someone is being treated, is being has gotten a treatment against his chronotypes. We see this in a clinical way, but this is something this is the type of chrono medicine that's coming towards to us. Everyone is interested in the 24-hour cycles, to sleep science, but we also should think about where are we going within our hospital routines, where everything is fixed to the morning, nothing happens in the evening, and at 8 p.m. the light is turned off. Patients should sleep, and we're surprised to see patients getting up at 4 a.m., 5 a.m., 6 a.m., and then they are being diagnosed for a sleep problem and they're getting medication. So it's about the hospital routines, also nursing home routines, and free living cycles we are now aware of.
And you said that there's quite a bit of restless leg syndrome with the patients. Have you tried to measure this, and do you see advantages if you would measure it?
No, it's not from our group, but there are trials, especially from sleep science. They are doing this in a big ways, because the restless leg syndrome is also during the whole lifespan big problem in sleep medication, sleep science.
Yeah, and about the circadian disruptions, you said that people kind of have their own rhythms, but the hospital is not adapting at all to those. How do you see this, and have you been doing some studies on relation to this?
We see this as an upcoming issue for the next decade, because we have done this exercise carousel, having 4 times exercise a day, promoting this rest activity cycle, and we see these are single cases where we see that patients have the same medication over the 14 days. They're starting with the baseline measurement, having totally disrupted day-night rhythm, and this is a stabilizing way of exercise, and they got a clear day-night rhythm for the measurement. This is something we now have, but this is extremely hard to analyze, because if you're summing up all these day-night rhythms, you get a mean level of physical activity. We are on a way towards this, quantifying this mobility-related circadian rhythms, but we're not quite there right now. Within rodents, within laboratory animals, there are some synchronizing effects. We see that this is an option also in the whole level of jet lag phenomenon, that exercise could serve as this Zeitgeber, and especially if we see that our patients, they suffer from this calcification of the suprachiasmatic nucleus, where the melatonin is also produced. We see that this is in an aging course. We see this as an upcoming issue, and we all know that the timing of physical exercise also brings effects to the night, or also to the next day. It is not only what to do and how to do, but also when to be active. This is something we're very interested in, because we see that the patients, well, they have lots of differences in how they're reacting, how they see the effects on this stimuli.
And do you think there will be in timing that all people should do it in a certain way, or do you think it's just about getting a routine that you do the physical activity every day at the same time, like you should do with eating and other things, that you have better sleep?
I think stability is important there, having these routines together. We see that an entrainment could work, that we give a small exercise session here there, and the other way would be to work counterwise against the current rhythm in order to stabilize these day-night shifts. But we know also from the rodents that working against the inner body clock would not bring us these levels of BDNF as before, or another way too. So if we look into the laboratory analysis, we see that we have these together with a chronotype of a person's being able to react to a chronotype could be the way, and then being able to entrain this cycle could be a way. But this is not only a way for the acute care situation. This is a way everyone should be aware of. And we see the interest of the society in this, not only work-life quality, but also work-life sleep quality, having the 24-hour cycle in mind, and going towards the geriatric patients. This is a major issue, especially in dementia, delirium, depression. What happens during the night? What happens with the chronotypes? This is perspective.
Yeah, and you are studying this. What kind of settings you have? How do you approach this one?
Well, we're in the acute geriatric psychiatric care setting, where the reason for admission is mostly neuropsychiatric symptoms, and one key is this disrupted day-night rhythm. Because if you're living at home and you get your partner has a disrupted day-night cycle, you cannot manage this anymore on your own, because you have to do your activities of daily living during the day, and the patient, the partner, is inactive during the night. So you need a 24-hour support. And we get these patients into the hospital. We're studying this right now with these disrupted patients, where we see these cycles also having the clinical records, what happens there, having the 2 ways with using the actigraph because it's the gold standard in in ambulant sleep quality measurement, and we're using the hybrid motion sensors on the lower back. We also have access to a longitudinal study, a data set where we seek to analyze the circadian rhythm of the step counts, not only having the counts from the actigraph, but also using steps and seeing, okay, when is the active period and inactive period, the timing of physical activity during the day, correlating to quality of life, correlating to morbidity. This is quite cool.
Yeah, sounds good. And I think I have gone everything from my notes. Is there something you would like to add in the discussion?
I think we got the major points. We see that the physical activity is coming a vital sign in geriatric healthcare that we should think about in the general practitioner setting, hospitals, and especially transsectoral care. I think we'll come to the point where we have also personal training at the homes of the patients, not only having a rehabilitation in hospitals, but also at home. And we see that motion sensors capturing physical activity and doing something with it, deriving physical activity interventions, is the way we should go for especially structuring the physical activity programs. And well, we see that physical, mental, and especially social active aging as the key ingredient for keeping and gaining quality of life in older adults. That where we hope to be able to help the patients for this active aging.
So you mentioned exercise referral, and I had a podcast recording. Now the name is escaping me, but she was talking about clinic flow, that how exercise referral and how it's difficult to do if you don't integrate it into the clinic flow or the way the things are done in a hospital or with outpatients. How do you see the clinic flow from your perspective and in German settings?
We've got the referral as part of the admission to the next hospital or admission to the next setting. So the discharge management is important. Patients, we can only have a first impression or first impulse into the acute care and then go over the next sectors, because we see the post-hospital syndrome. Patients receive morbidity that has nothing to do with the acute illness. Why they are in their hospitals, they are lying the time, they're sitting the time, and they don't come back to the level of functionality. That's why we see the exercise referral should focus on the transsectoral care, and then aiming having the activity levels in the patient's homes, because in the future we also won't have enough space in the nursing homes. Everyone should be able to stay as long as possible in their homes, and key ingredient will be the physical activity and the exercise prescription by the general practitioner, by the hospital, by the physiotherapist. I think it's the multi-professional approach that should lead us to this goal.
And how do you see current situation with the pandemic and long COVID? There's some scientific studies showing that the virus does enter the brain, or it's been found there, at least from the long COVID patients, and the brain fog and difficulty in concentration is reported a lot. How do you see this affecting the the hospital populations? What's your take on this as an expert in neuropathology?
Yeah, it does not only affect the hospital group, but also the patients staying at home, all the people staying at home, and We see after with this coronavirus pandemic, also the pandemic of physical inactivity. This is intercorrelated together, and we see therefore the side effects of the inactivity pandemic. We see this in the hospitals, but also at their homes. We have the counter development also, that patients are aware of this. They know, they see that they are moving not enough. Decreasing functionality is the problem in there, and we see as a key for this is quantifying the physical activity and then doing the personalized referral for the like those response effects, or like you're saying, the mechanics that have these brain tissue adaptations. We don't know many about this yet, especially in the higher age population. This is something we will work on, and keeping this in mind.
Yeah, a little bit worrying developments. How is your research group? Are you looking for some kind of collaboration? Do you want to promote anything here, a job position or a book chapter or whatever?
Yeah, and marketing is daily work. Well, we're on Twitter. Follow us on Twitter. We're doing science communication. This is important for us, for also bringing this for the students together. We're open for collaboration with, especially in the field of circadian rhythms. We seek, therefore, analysis approaches. We're placed within the community, but also see your podcast as a way for especially speaking about these topics, and therefore we're very thankful.
Yeah, it's been very nice discussion, and I also learned a lot about pathologies, neuropathologies. So it was a really interesting discussion. So thanks for Tim taking the time.
Thank you, Ollie, and thank you, listeners.